Hello and welcome. On behalf of CME Outfitters, thank you for joining us. Today, we will be discussing the role of genetics in ALS, who should be tested. This is the second activity in 3 CMEO Snacks series supported by an educational grant from Biogen. I'm Dr. Jinsey Andrews, and I'm the Director of Neuromuscular Clinical Trials at Columbia University Irving Medical Center. I'm joined today by Dr. Amar Al-Chalabi.
Hello, I'm Amar Al-Chalabi. I'm a professor of neurology and complex disease genetics and director of the King's Motor Neurone Disease Care and Research Centre at King's College London in England.
Our goal is that after this CME snack, you will be able to employ genetic testing in patients with ALS based on the knowledge of genetic pathophysiology in ALS. So today we'll be talking about genetics in ALS. And it's important to note that people living with ALS are very individual. The disease presents itself very differently from person to person, and there's different types of ALS. Dr. Al-Chalabi, what are some of the different classifications of ALS?
So that's a really important question, but actually partly depends on the reason you're classifying. If you're classifying to give a diagnosis, then it makes sense just to call it ALS. But within ALS, there are different patterns of presentation, and sometimes those are given various names, such as primary lateral sclerosis or progressive bulbar palsy. But another way of classifying is based on the cause of ALS. And for some people with ALS, we do know the cause because there is a genetic variant that has a large effect and is the cause of ALS in that person. Now, in the past, we used to think that was familial ALS, because it was usually associated with a strong family history. But we now know, with the advent of modern genetics, that actually even people without an obvious family history can have some of these genetic variations. So although having familial ALS is often a strong indication of some genetic variant being in the family, it is possible even without a family history to carry some of these genetic variants, and therefore probably a better classification than familial versus sporadic ALS, which is the traditional classification, would be genetic versus non-genetic ALS.
I think it's also important to note that a majority of patients living with ALS are classified in the sporadic category without an identified gene or a known gene that's associated with their ALS. But as you mentioned, even in people who have ALS with no family history, it's important to consider a potential genetic cause. And there are many, many, many genes that have been associated with ALS. And of course, that number continues to grow. What are some of the different genes and mutations that are known to play a role in ALS?
Well, the first gene discovered to have a role in ALS is called SOD1, and that was identified in about 1993-94. And despite us finding it so long ago, we're still not absolutely sure the actual way it causes ALS. We don't really know why people carrying variants in this gene subsequently develop motor neuron degeneration. SOD1 variants affect about 2% of people with ALS, so the majority of people don't carry those variants. Depending on the population, about 10% of people, up to 10%, may carry variation in a gene called C9orf72, which I prefer just to call C9 for short because it's easier to say. And that variant, again, if you carry it, it greatly increases your risk of ALS, but doesn't definitely mean that you will develop it. And mutations in the single mutation in C9orf72 that seems to be responsible is an expansion of the genetic sequence. So it's slightly different from most of the other causes of ALS. That also seems to be responsible for a related condition, which is frontotemporal dementia, and may also increase the risk of other neurological or even psychiatric conditions. Two other important genes are TARD-BP, T-A-R-D-BP, which codes for a protein called TDP43, and that protein accumulates in the cells of people with ALS. Mutations in that gene probably account for about 1% of people with ALS, and mutations in the FUS gene, which is related to TARD-BP, probably account for about another 1%. So those are the big four in the UK, and I think probably in the US, is that correct?
Definitely. Also, because we're in New York, we deal with a diverse group of people, diverse populations, and certainly it has posed some challenges for us in trying to understand gene mutations in those diverse populations. Do you have any comments about the knowledge of gene mutations in diverse populations?
So we have a similar situation in London. Of course, it's a very diverse population, and actually in many other parts of the world, many of our colleagues will have a similar kind of issue. I think part of the problem is a lot of the genetic studies that have been done that give us the information of which gene variations might be common are done in predominantly European and now East Asian populations. So I know that in Scandinavia, for example, TBK1 mutation it's a completely different gene, is more common than TARD-BP or FUS mutation. And in the Netherlands, for example, SOD1 mutation is very rare. And other parts of the world are less well represented. And so it's very difficult to really know whether the genetic profile and the genetic architecture of ALS is the same in all the different populations across the world.
Definitely. And it does create a growing need to understand which gene mutations are relevant for your region and for your population in that specific region. Both of us are in ALS clinics. We see large numbers of patients. I'll ask you first, and maybe I can comment a little bit about how we would go about it in the US, but what kind of panels or testing, how do you go about testing people living with ALS and their genetics?
So the very first and most important thing is to counsel the patient and their family. So it's very important that people understand all the implications of genetic testing, the implications of a positive test, the implications of a negative test, and the implications of an uncertain test. Once that's been done, and that may be a long process because it's important to cover all the different points, then we usually do a tiered approach, a kind of pyramid testing, where we will test those 4 big genes that we mentioned already. And then we may go on to perform whole genome sequencing. So that's where, instead of doing a panel of genes, we will now simply screen all of the DNA of that person. That's a relatively new development. Until recently, we used to simply screen a slightly bigger panel of genes. So we used to go from about 4 genes to about 40 genes. But now we go from 4 genes straight to whole genome. What do you do in the US?
You know, in the US, we also focus heavily on the big 4, the big 4 genes that you discussed earlier, which includes the SOD1, the C9, the TARD-BP, and FUS. Recently, because there's been grants provided to sponsor genetic testing, it's reduced some of the barriers to getting genetic testing, which includes the cost and insurance coverage here in the States. And so often when people come in as their initial clinic evaluation, we will have the genetic counselor if that's available. So from our clinic in New York, we do have a genetic counselor on our team. They'll meet to introduce the concept, kind of obtain the family history and discuss potential genetic testing. And then in follow-up, we're able to obtain for more patients genetic testing through panels that cover about 25 ALS genes. And then usually there's a separate test or a different type of test to obtain the C9 genetic test, because that is as you mentioned, a hexanucleotide repeat.
Can I ask you, Jinsy, there are other genes that we haven't talked about which increase risk quite a lot compared to the background of the population, but not as much as the genes we've been talking about, which are often associated, but not always, with the family history. And I'm thinking of genes like UNC13A or ataxin-2, where variation in those genes may triple your risk of ALS, that kind of amount. So it's not making it very likely you'll get ALS, but certainly increasing your risk significantly. Do you screen for those genes?
Interestingly, we do have a heavy genetic focus in our clinic, and we have physicians who specialize in genetics and genetic counselors. We don't routinely test the UNC13A risk gene, for example. But because of the growing literature, there's a lot of discussion here in the US about screening for those, mainly because it's not actually on the panel that's sponsored, or free actually at the moment in the States. The second is ataxin-2. I think that has grown in knowledge and also in importance because there are clinical trials targeting the ataxin-2 gene, necessitating that test. So it's only a recent development that we've been trying to test people living with ALS for that ataxin-2 gene mutation.
Right. So for us, UNC13A also has a targeted trial. It's not a gene therapy, it's using a medication, but it's targeted at people carrying that genetic variation. And the other reason we screen for it is because it can affect prognosis.
Two very key factors, I think, that influence practice and also necessitate changes, especially if there are clinical trials or experimental therapeutics that are targeting specific gene mutations.
You mentioned genetic counseling. What do you think are the benefits of genetic counseling?
From my perspective as a clinician, having a genetic counselor, or even prior to that, I've even had to do genetic counseling as the physician caring for a person living with ALS. It's very important for people who get a genetic test to understand why you're doing it and how it affects not only them, but also their family members or their relatives before actually getting the test. And it's also important to understand what that information will empower them to do. So will it change the way they go through the journey for the disease and obtain their care? Will it change which trials they'll pursue? And it also is important for them to talk about what the risks and benefits are about genetic testing. So I think those are really the benefits. And I think some of the need to have that genetic counseling component before and after once you get the genetic test result.
Yes, I think it's also slightly different, or very different, in people who have a family history where they may already know quite a lot about ALS and they already understand that they may be at risk, compared to people who have no family history and ALS has just come out of the blue, because the implications of a positive or a negative test in those two situations are quite different.
I definitely agree. And when you get that genetic test result, I think I go back to what something you mentioned earlier about clinical trials. It's important to really understand what clinical trials are enrolling in the region that you're practicing, especially for ALS. And you mentioned UNC13A. Are there other gene mutations that might have clinical trials in your area?
So we have trials at the moment for genetic therapies targeting SOD1, targeting C9orf72, and also, as you mentioned, targeting ataxin-2. There are also trials I'm aware of that will be targeting FUS. So yes, and I'm sure there'll be others in the pipeline that I haven't heard of, but those are the ones that are available in our area.
Yeah, in the US, we have similar clinical trials that are looking for people who have the C9 mutation, the SOD1 mutation. In New York, we are actually actively enrolling for the FUS mutation and using experimental therapy targeting that specific mutation. So it's become increasingly important to screen individuals that might be newly diagnosed with ALS for a gene mutation that potentially might be associated or associated with their disease.
Indeed, some of these mutations definitely cause ALS when they're found in that gene, and there's good evidence that they will. But sometimes you find mutations that perhaps there's less evidence, or they've been found only in 1 or 2 people, and so we don't really know, is it just a coincidental rare variation, or is it actually causative? Do you think that affects enrollment in trials? It certainly affects what you tell the patient, doesn't it? But does it affect enrollment in trials?
I think it makes it difficult from the clinician perspective when we're discussing clinical trials. Often when I am presenting a clinical trial, and I do participate in some of these trials using experimental therapies to target specific gene mutations, often when I'm speaking to the individual carrying the mutation, there isn't much concern about the role of that gene mutation and whether it's a risk or it's causative. They really, because of the lack of available treatments for ALS, it really, their drive is if they found something that might have a small chance in influencing the disease burden in their body, they are willing to participate and take the risk.
Yes. The problem, I suppose, though, is that if you're designing a trial, you need to make sure that the people enrolled in that trial have ALS because of the target, because of the thing that you're treating. And so you need gene adjudication panels that decide whether somebody can be enrolled in a trial. And I know that can be a problem because somebody, as you say, essentially the threshold, if you're entering into a trial, is different from the threshold if the treatment is already licensed and available. Because I agree, I think if there's a gene therapy available, then and if it's safe, then your threshold for enrolling somebody, even when you're not certain that disease gene variant is causing ALS, would be low. You'd be very likely to enroll them. But in a clinical trial, I think the barrier is much higher because the trial team need to make sure that only people with their disease definitely being caused by that gene variant are being treated, so that the trial can really detect an effect if there is one.
I have to agree. Just going through the process of enrolling for clinical trials like this, I know living through that experience, we identify common mutations like, for example, FUS mutation, but it might be a variant of unknown significance. And there are often gene adjudication committees that can evaluate to see whether it is something that's causative or not. But it is, from the patient perspective, it is often stressful to go through that period because there's so much interest from the patient perspective to participate in a clinical trial.
The resource implications that you were talking about there are actually huge, not only in terms of just having people able to deliver the counseling, but actually in terms of time, because it can take an hour and a half, 2 hours to have these conversations. And if you're doing that in a specialist center and the person's had to travel a long way to get to the specialist center, because there obviously aren't many because they're specialists, then you're making a very long day for somebody who's already physically finding it challenging because of fatigue and disability. You're giving them an even longer day by adding in this counseling. I think remote consultation actually is helping with that to a large extent, but it is a big challenge.
For us, it's definitely a challenge. Based on the certifications for a center of excellence, you require multiple disciplines to come and see somebody with ALS. So not only does the physician or the nurse see the person, but also a physical therapist, occupational therapist, respiratory therapist, speech therapist, and then you're adding the genetic counselor on top of it. And often for us, operationally, the genetic counselor does do a video visit. And in the US, there are licensing requirements in each of the states. So your genetic counselor who does the video visit needs to be licensed in the state where the person living with ALS is at when that video visit occurs. Dr. Al-Chalabi, do you feel that every ALS patient should be tested or screened for a genetic mutation?
I think every person with ALS should be offered genetic testing. But of course, if they don't want to be tested, then they shouldn't. But doing that does pose many problems. Most importantly, apart from the implications for things like life insurance for the individual and for their family, it also poses problems because of this difficulty that many of the variants we identify may be, as we term them, variants of uncertain significance, where we don't know whether they're risk variants or benign, and we can't predict it in any useful way. And so the person is left with an apparently possibly positive genetic test result, and that's quite distressing and quite difficult to even explain to people. And I think that's combined with the fact that some of these gene variants also have reduced penetrance, where you can carry the gene variant, but it's not necessarily going to cause ALS in your lifetime for you. And so you've got all this uncertainty around an apparently positive genetic test result that can be very difficult to communicate effectively.
It's especially hard because often when I see someone who's newly diagnosed, they ask, why do they have ALS? And often I don't have a clear response, and that can be unsettling. Especially because they've gone through rounds of testing, MRI imaging that was normal, blood testing that was normal, and really it's almost shocking to people who get newly diagnosed that they're diagnosed with such a progressive and fatal disease, but it's based on a clinical diagnosis.
Yeah.
I think it's important in the US, in New York, at our center, and this can be very variable in the US, in terms of each ALS center's resources and capabilities. But at our center, because we have genetic counseling, we do screen everybody for gene mutations. And especially since there are clinical trials actively searching for potential participants. But this, as you mentioned before, carries some risk. And in the US, we do have some laws that are passed to protect people from discrimination based on their genetic information that may cause disease or increase their risk of developing an inherited disorder. And so that law is called the GINA law, and GINA stands for the Genetic Information Non-Discrimination Act. And it's essentially to protect an individual from discrimination in two areas. One is in employment. So an employer cannot discriminate or prevent you from being hired or promoted or gaining other benefits or terms of employment based on your genetic information. And the other is in the health insurance sector. So health insurance carriers cannot deny you coverage or consider your eligibility for coverage based on your genetic information. So there's some protections provided in the US, but these and some other laws that have been passed don't necessarily protect you from everything. So as you mentioned, life insurance, disability insurance, and long-term care insurance, the GINA laws don't protect individuals from that. So it's important to have that conversation. And most genetic counselors are pretty aware of that in the US and have that discussion before the genetic testing is planned.
Jinsy, do you have a policy in the US or in your clinic or in other clinics that you know of where people without a family history are more likely to be tested if they're young than if they're old, under the assumption that genetic ALS is more likely to occur in people who are younger than older at onset?
Although the ALS specialists, I think in the US recognize that as a fact, it's not necessarily in any guideline or policy. And it may not necessarily be always the case that somebody who's young that presents to an ALS center gets offered a genetic test. And this is where it's really important to recognize that genetic testing should be offered to anyone who has been diagnosed with ALS, and it carries implications for experimental therapeutics, for their family, and for family planning for those that are asymptomatic.
Yes, absolutely. And actually, we've shown recently that regardless of age, there is a risk of genetic ALS. So you shouldn't be restricting testing by age.
Right. So the assumption is just because someone is older when they present with ALS doesn't necessarily mean that they don't carry a gene mutation.
Correct. Yes. Although gene mutations generally lower your age of onset, the effect is small the other way around, so that it doesn't make that much of a difference testing in terms of the probability of a positive test.
I wanted to go back to something you mentioned, which is something I find challenging, actually, because genetics, although I have to know it and I apply it, I'm not a geneticist by training. And so often, because we're screening everyone who comes in for a gene mutation, we do get the result of a variant of unknown significance. So we talked a little bit about it in the clinical trial setting, where there's a committee I could go to, and they can adjudicate for me. But how do you interpret results of genetic testing, and how do you go about it with people living with ALS?
Yeah. So when the test is clearly a variant that's well known to be causative for ALS, I think it's straightforward, and you can at least explain that we know this has a large effect. It's a large contributor to the reason the person has developed ALS, and that there may be a gene trial either available now or in the near future that they may be able to enroll in. And if it's clearly a normal gene test result, which is actually the most common result, isn't it? That is also, of course, relatively easy to communicate, although, of course, you do have to explain that we don't know every single gene that causes ALS. And so it doesn't mean it isn't genetic, it just means it's unlikely to be genetic. But yes, these variants of uncertain significance are extremely difficult to explain and to deal with, and even actually to identify, because there's no good way of predicting if a variant is going to be pathogenic, is going to be disease-causing or not. There are no good prediction programs that will take that gene sequence and say, well, it'll make a protein that looks like this, and therefore that's going to be disease-causing or not. And that's a lot of that is because we don't actually know the mechanism of the disease for ALS. Despite knowing the gene variants and all of these different genes, we don't know why they necessarily cause ALS. I think we're beginning to learn it for some of the genes that have been identified. But until we do know that, it will be very difficult to know how to deal with these variants of uncertain significance and really how to communicate that information.
I agree. And I think one of the challenges that healthcare providers and even genetic counselors face is when you get that variant of unknown significance, often the person living with ALS comes with their family members. And how do you deal with the family members and the risk to the family members? Yeah.
And especially if there's no family history, of course, that makes it difficult compared to if there is a family history. And as we said before, it's compounded by this variable penetrance that we see.
Yes.
We do know that regardless of family history, if you have a single person with ALS then their first-degree relatives have a slightly increased risk of ALS. It is only a small increase, and it's a technical increase, so in practice it doesn't really make a difference, but it does suggest that there is this underlying genetic contribution to all ALS.
The genetic information that you get after screening somebody for a gene mutation, how does it inform your disease management and approach to a person living with ALS?
Yeah, so I would say that really depends on how far through the disease process they are by the time they get the result. But in many cases, it'll help clarify the disease progression as it may well turn out. So for example, somebody with FUS mutation, FUS mutation, they're more likely to be young at onset. It's more likely to be a very rapid disease. Somebody with C9orf72 expansion mutation, they're more likely to have cognitive impairment and perhaps a family history of cognitive impairment, frontotemporal impairment particularly. So it does impact the way we manage it, because I would, in somebody with a C9orf72 expansion mutation, if they hadn't yet had cognitive testing, I would make sure that they definitely did. And I would be counseling the patient and the family about those aspects of care. What about for you?
I think you made a really important point about some of these genes we do have some information on. So we may not know how the genetic mutation functionally causes ALS biologically, but we do know some clinical features that we really need to be alerted for. So there are some mutations of the SOD1 gene, and as you mentioned, the FUS gene, that are rapidly progressive, and we know that. And so it requires the healthcare team to be very proactive and aggressive in the interventions that we provide, not only for approved therapies, but also for supportive management to ensure that we maintain the best quality of life for people with those particular mutations. So it gives some degree of anticipation, and we are able to be proactive in their care. I think also it's important that I mentioned family often comes with people living with ALS for their visits. And if there's a gene mutation identified in the person living with ALS, often there are questions, and I'm going to throw back another question, but often there are questions about how it may affect them, and that's included in the genetic counseling. But I wanted to ask, in your center, do you actually discuss or deal with the family members or screen those asymptomatic or pre-symptomatic individuals for ALS genes?
So we certainly don't do it routinely, but we will do it in certain situations after proper discussion. And particularly the group of people that's most likely to be tested in that way are younger people who might be wanting to start a family when there's a positive diagnosis of genetic ALS in a first-degree relative, because there is the possibility of pre-implantation genetic diagnosis where, as you know, it's a form of IVF. So the embryo is tested before implantation. The person never needs to know their own genetic status. You just test the embryo, and you only implant an embryo that doesn't carry an ALS-causing gene variant or an ALS-associated gene variant. So that would be the main situation we would do that. There are clinical trials coming online that are looking at preventing ALS onset, and so I think that would be another reason to start doing it now, but it's certainly not something we do routinely. What about for you?
For us, at our center, we don't routinely test individuals that are asymptomatic or pre-symptomatic. However, there are observational studies in the US of looking at cohorts of relatives of people living with ALS, and those relatives or individuals may choose to participate in that observational study once they've signed an informed consent and talked about the risks and benefits. And in those observational studies of family members who are asymptomatic, of people living with ALS associated with a gene mutation, they can actually get screened under research purposes. So again, the records are kept private. They are not something that can be taken by insurance companies and things of that nature. So that data is protected. And in some of these observational studies in the US, asymptomatic or pre-symptomatic individuals may choose not to know whether they tested positive or not. So there is some flexibility there. But there are studies, and I should point out that there are studies looking at pre-symptomatic individuals with the SOD1 mutation. So that kind of necessitates sometimes a discussion and screening for that particular gene. And I think as more experimental therapeutics come that target specific genes, it'll kind of push the practice, right, to look more closely at gene mutations, not only of people who are symptomatic, but also those that may be asymptomatic or pre-symptomatic. Let's summarize with our SMART goals: specific, measurable, attainable, relevant, and timely. That is what we hope that our audience will take away from this presentation to apply to your practice. So some of the goals that we hope that you're able to take away from today's CMEO snack is to recognize the role of genetics in ALS onset and progression, to appropriately identify who, when, and what to test, and lastly, to interpret and apply genetic testing results to inform disease management. This CMEO snack is one of a three-part series. We hope that you'll take advantage of all the short and focused activities in the series, including meeting the challenges, improving diagnosis of ALS, emerging gene therapies in the fight against ALS. Thank you once again for joining us today. Be safe and take care.